Okay, so welcome everybody to this didactical activity of the DCB Academy. From all of the fellows, we have a group of 16 fellows from all around the world. And this activity is done for CR, which is the CRO, which is taking care of many clinical trials, including Transform 2. So for us, it's so important to teach you about the novelties in interventional cardiology. And all of the fellows that are helping me in doing this and in achieving this goal are pretty much aware that you are not physicians. But anyhow, please let us know in the next future if the didactical activity is good for you, or if you would like to have some other information or whatever. And please also interrupt us for any specific doubt or request or something that we need to rephrase or whatever. So today we have Antoine Elcoury, which from Paris will hold a lesson on complete versus non-complete revascularization in current era interventional cardiology. So Antoine, please, the podium is yours.
Okay, I will share my screen first of all. I will try to share it. Okay, can you see the slides?
Yes, perfect.
Yes.
Okay, great. So good morning, everyone. I will present myself first. I'm Antoine Elcoury. I'm a cardiology fellow. I'm currently working in Paris, in my final year of training. I would like to thank Dr. Cortesi for this chance for me to present this lecture. So as we said, we'll present a lecture about complete versus non-complete revascularization in the modern era of interventional cardiology. Complete meaning if a patient presents with myocardial infarction, ST elevation MI, and has multivessel disease. So non-complete is just to stent the culprit vessels, the vessels that cause the myocardial infarction, and complete if we need to do the complete revascularization for all the vessels, not just the vessels that cause the myocardial infarction. So we'll discuss this today, and we try to answer this question to see if we have to do all the vessel or just the culprit vessel, and in certain population like cardiogenic shock or high-risk vessels, and when do we have to do the complete revascularization, if we have to do it directly on the spot on the initial exam, or we stage it for a later admission, and if we have to do the revascularization by PCI, by stent, or by coronary artery bypass graft by surgery, or just medical treatment. And we need to see if there is a role of FFR in the decision-making, and the role of OCT, which is an intracoronary imaging, to evaluate these patients.
Yes, Antoine, sorry to interrupt. This is a very important topic and area still in the field of developing new indications. There are still some ongoing trials on the topic because, you know, the fact is that myocardial revascularization in the setting of acute coronary syndromes have reached a quite clear indication in terms of reduction in adverse events. However, for stable patients and for stage procedures, the clinical indication for doing a complete revascularization is not clear. So we still have a clear idea on which patients and when and how they should be treated for a completeness of revascularization.
Yes, exactly.
Please.
Okay. So the guidelines, we have the recent guidelines, 2021 ACC guidelines that mention these topics. And we have a class 1 level of recommendation A, meaning that we have to do this in patients that present with ST elevation MI and are hemodynamically stable, that are not in cardiogenic shock. We need to stent the culprit vessel first, the vessels that cause the MI. And we have, if we have additional lesions and other vessels that need treatment, we need to do it. We need to do complete revascularization, but it does not have to be in the same time. It has to be a stage PCI. So we need to tell the patient that we will do the rest of the arteries in the next time, but we need to do them all. So it has a mortality benefit to do the complete revascularization. As opposed to here, as you can see, the one in red, the last one in red, it's a class 3 recommendation. So we should not do this for patients that present with ST elevation and MI and are in cardiogenic shock. We just need to stent the vessels that we think has caused the MI. If we do the complete all the vessels at the same time, it's risky for the patient, and it's associated with high risk of death and renal failure. So we need to avoid this, and it's contraindicated in certain places. So we need just to do the culprit vessel in case of cardiogenic shock and ST elevation MI. So to make things a bit clear, I will just discuss few cases, complicated cases. All these patients had cardiogenic shock or VFib during PCI. They all presented with ST elevation MI. So the first patient is a 48-year-old woman with a history of lupus. So it's risky, so it can cause coronary disease and smoker. She was a smoker as well and hypertensive. She presented with ST elevation MI. As you can see on the ECG, we have ST elevation in the inferior leads 2 and 3, and AVF. So when we look at this ECG, we need to suspect an occlusion or a disease in the right coronary artery. And the patient had also a heart block as a complication of this, but it's not shown on this ECG. But it was so ST elevation MI was a complicated case. So it's not just a normal case. So a coronary angiogram was done, and it showed, as you can see on the figure B, on the red arrow, we have a severe lesion of the right coronary artery. I don't know if you can see the pointer. I will try. It's here, 80% lesion of the right coronary artery. But we have also lesion in the left anterior descending artery.
And Antoine, if I may add something, that's the aspect of that lesion on the RCA is a quite complicated plaque. Yeah. It seems a ruptured plaque with also some thrombus in it. So it's for sure, according also to the findings of the ECG, the culprit lesion. So in this case, the culprit lesion was quite clear. In some other cases, it is more difficult to understand it.
Yes. Here, the ECG shows changes on the inferior leads, so most probably it's the lesions that caused the myocardial infarction. And you can see that a stent was placed, and you can see on the figure C, after the stenting, we have opening of the vessel. We had lesion of the left anterior descending artery, as you can see in figure D, and the rest of the left anterior descending artery was a small artery and full of disease. So they decided to just stent the right coronary artery first, according to the guidelines. We need to stent when the patient is in cardiogenic shock or complicated case. We just stent the culprit vessel and we do the rest in a later time. But this patient, 3 days later, started to have chest pain again. So typical chest pain again with ECG changes. So they decided to stent the left anterior descending artery 3 days after the first one. So it was a staged procedure, and we did just as the guideline said. And after that, she had a stent in the LAD, as you can see in figure E. The vessel was reopened, and the angina resolved, and the patient was free of symptoms, and she was discharged later on. So according to the guideline, we said that for patient with STEMI and complicated cases like cardiogenic shock, like this case, we just need to do the culprit vessel, and we need to do the rest of the vessel in a stage procedure in a different time, as we did here after 3 days. So this will prove that the guidelines need to be followed in order for the benefit of the patient. Okay, so I will move now to a second case. Here is a 74-year-old man with diabetes, hypertension, presents with ST elevation myocardial infarction. As you can see on the ECG, we have ST elevation in anterior and in lateral leads, V2, V3 to V6. So here we suspect a disease maybe of the left anterior descending or the left circumflex artery. So a coronary angiogram was done, and the coronary angiogram showed an occluded left anterior descending artery. As you can see in figure B on the red arrow, we have an occluded LAD. We also have disease of the right coronary artery, but here we don't have the image. And we have a disease of the circ, 80% ostial circ stenosis, as you can see on the figure D, and 60% stenosis of the obtuse marginal branch of the circumflex artery. So here we're in front of a patient with multivessel disease, but the culprit vessel, according to the ECG, normally should be the LAD, which is an occluded vessel. So here you can see here it's a video, but okay. You can see that they attempted to put a stent on the LAD, but the patient experienced no reflow after the stent, and he went into ventricular fibrillation as a complication and in cardiogenic shock. So he was shocked and went back to sinus rhythm, but he remained in cardiogenic shock despite stenting the LAD and despite having a normal flow after that. So here we think that even if we stented the LAD, which we think is the culprit vessel, but the patient remained in cardiogenic shock, so maybe we have a different culprit vessel as well. So they decided to stent as well the left circumflex artery. So we did.
Antoine, excuse me. This is the final result before the circ. This is the intermediate result with
yes,
with another
when
flow.
the patient developed VFib.
Yeah, because it's a very long stent. So probably there are 1, 2, 3, or more stents implanted here.
It was a long
so
stent.
Do you think it was also needed to implant a stent also in the left main and all the way along?
The left main was okay, so I think they could have just put a smaller stent, maybe, because we have also a disease in the circ. So they need to, if they want to cross to the circumflex artery, it will be a bit complicated with a stent in the left main as well. I think. I don't know if you agree with me.
Yeah, well, we should see the procedure. Still, in some cases, we go with manual thrombus aspiration. I don't know if this was the case, but when we see a big clot or a totally occluded vessel, mostly in the LAD, we still use manual thrombus aspiration, and we retrieve a lot of clots from the coronary arteries, despite the guidelines now state that you should do it only in selected cases. But in these cases, we do it. And we have seen that the risk of no reflow is much lower when we do this. Yes. This is one point. The other point, we should see how is the lesion after manual thrombus aspiration. And as per our experience, we just put a short spot stenting, because the more you stent here in these cases, the higher risk of acute and also on the long-term complication is.
Yes. Okay. So here they decided to place as well a stent on the left circumflex artery because the patient did not improve even after the obstruction of the LAD. So a stent was placed in the left circumflex artery with good results, and the patient was stabilized and was out of cardiogenic shock a few hours later. So this case is to show that here we sometimes we can have two culprit lesions, so we need to stent both even if the patient is unstable. So we need to stent the two culprit lesions in this case. Okay.
So yeah, it's okay. Well, what I would ask, well, you didn't do this case, or you did it?
No. This case was published in the
JACC. Yeah. Well, we can see a quite nice tube here on the LAD proximal to the distal part. But what we have to understand when we put stents or we use any type of device for coronary vascularization is how is the territory. So in the end, what we have to heal is not our eyes or the coronary artery. We have to heal the myocardium. So if we do a good job, it doesn't mean that we need to put a lot of stents and to create big vessels if we don't have a specific and a deep care of the microvasculature distally and of the myocardium. So I don't know how was the case. I should ask you for more information regarding also on the short-term outcome, on the left ventricular ejection fraction after a few days and so on. But what we have to keep in mind is that we don't have to only do good coronary arteries. We need to think above this.
Yes. Okay. Okay. So there were also remaining lesions of the OM1 and RCA lesions. These lesions weren't stented initially, but they were stented on a planned procedure later on, and it was according to the guidelines. It was class 1A to do the complete revascularization to decrease mortality. So they did the RCA and the OM1 later on, and the patient had complete revascularization. He had a stent in the LAD, a stent in the circumflex, or proximal circumflex artery, and later on a stent in the OM1 and RCA. So it was a complete revascularization. Moving now to the last case, it's case number 3. It was a 66-year-old man. This case was also published in the Journal of American College. This case was a STEMI due to occlusion of the right coronary artery. As you can see in figure A, we have an occlusion of the right coronary artery, but we had also disease in all the vessels. It was a 3-vessel disease. We had disease in the left main, 60% stenosis, and we have disease in the mid LAD, 70% stenosis, as you can see in figure C. And we have also disease in the obtuse marginal artery, which was a severe disease of 90%.
Excuse me, Antoine. I have a question for the guys here.
Yes.
Do you know how is the anatomy of the coronary arteries? So while Antoine is talking, you are understanding it?
Yes.
This is the RCA.
Yeah, Dr. Greco gave us a lecture about this, so we know what you're referring to pretty much.
Perfect. Okay. Thank you, Antoine.
Okay, so as you can see in the figure A, we have a thrombosis of the, we have an occlusion of the RCA, which we think it was the culprit vessel because the STEMI was on the ECG. We had signs that the inferior wall was affected, so it was the RCA. So the RCA was successfully opened. As you can see on figure B, a stent was placed and the right coronary artery was reopened. But as well, this patient had a complication with VFib, and he was successfully defibrillated, and he went a bit in cardiogenic shock and in AV block as well. So it was a complicated procedure, complicated by cardiogenic shock. So here, the question is, do we need to stop here, just send the RCA, and do the rest of the vessel in a later procedure?
I have a tentative answer for your question now, because it's a tricky case, and it's very didactical and interesting. So congratulations for having selected this. You know, my impression, is that the other lesions are, well, critical, yes, but probably do not influence the current clinical status of the patient.
Yes.
Here, the fact is that we don't have to forget about this right ventricle vessel, which is just originating a little bit proximally to the culprit lesion, but that we cannot see after stenting. So one of the key messages here, I don't know, I'm not sure that it was the reason for this ventricular fibrillation, for this dysfunction, whatever. But what is important here is when we place stents, again, we should put them as short as possible just to treat the culprit lesion, because the longer we place stents, the increased risk, the higher the risk for occluding also collateral vessels. And in the setting of acute MI, any vessel that we may lose can contribute to the worsening of the clinical condition of the patient. So probably in this case, this right ventricle ramus was very important for providing a good function of the right ventricle here.
Yeah. Yes, I think they lost a part of the branch because of that. The patient went in ventricular fibrillation and hypotension as well. Okay, so here they decided to stop here and to discuss this case in a heart team. The heart team involves a surgeon and interventional cardiologist. And because we have diffuse diseases and the disease of the left main as well, they decided to proceed with CABG, but later on, it was not an urgent procedure. The patient improved after stenting the RCA, but the rest of the lesion, according to the guideline, it's class 1. We need to do complete revascularization. And in that case, it was better to do a CABG instead of putting a stent in all the vessels, because we have also a lesion of the proximal left main vessel, in addition to lesion of the mid LAD and obtuse marginal. So it was a 3-vessel disease. So they proceeded with coronary artery bypass graft, which is a surgery to treat the vessel. As you can see here, according to the guidelines, doing CABG after primary PCI of the culprit vessel is class 2A recommendation. So it was reasonable to do it for this patient, especially in case of a left main lesion associated with all the other lesions. Okay, so to make things more clear, when a patient presents with ST elevation MI, and after successfully treating the culprit main vessel causing the MI, then we need to see if the patient is in cardiogenic shock or not. If the patient is in cardiogenic shock, so here, I'm not sure if you're seeing my pointer. Are you seeing it?
Yeah, the red one, yes.
Okay, so if patient is in cardiogenic shock, revascularization on the spot of all the vessels with the initial vessel is contraindicated. It's class 3, so we should not do it, as we said. But in that case, we need to see if the remaining vessels are of small diameters, so low-risk vessels. In that case, we can proceed to a heart team discussion, and we can then do just medical therapy. We don't need to stent the vessels, especially if the vessel diameter is so small. It's a risk also to put a stent in a small vessel. We can just do medical therapy, depending also on the echo results on if the wall is affected or not, on the myocardium or not. If the vessel is large, so here, and is giving blood to a large territory of myocardium, then we need to do complete revascularization with a stent or with surgery. So it depends. We need to every time we need to have a heart team discussion, so cardiologists with surgeons to discuss the case. So it's either we do a complete PCI of the vessel or we do cabbage. It depends on the case. It's case-by-case discussion. If initially
this is a quite a big shift as compared to the previous guidelines. You know,
yes.
Till a few years ago, in case of cardiogenic shocks, you were not. It was not a class 1 recommendation, but a 2A to go on with complete revascularization. But the data was quite, the scientific data and reliability was quite low. There was one single study of few hundreds of patients, not powered for that endpoint, which came to that indication. But later came out other studies, and which led to this flowchart.
Yes, the most recent study was a complete trial, and after that study, they changed the guidelines, and it's now class 1 to do the complete revascularization after this study. It was published in 2020 or 2019, if I'm not mistaken. Okay, so as a patient initially don't have a cardiogenic shock after stenting the initial vessel, sometimes if the patient is low-risk patient, a patient without a lot of comorbidities, and if the vessel is of low risk, meaning that it's not a bifurcation, it's not a left main, it's a regular vessel, we can sometimes proceed to complete revascularization in certain patients in the initial procedure. But as you can see, it's only class 2 level of recommendation B, so it's not very recommended to do this. It's better to do it, as we said in the 3 cases, in a planned procedure. So just stent the initial vessel causing the MI, and then after that, do the rest of the vessel in a different time. This was the idea of these guidelines, is to do complete revascularization. Okay, so these guidelines came, as we said, after a study called the complete trial. This study included around 4,000 patients in different parts of the world, and they concluded that patients that had complete revascularization within 45 days of the initial event had decrease in long-term mortality over 3 years. So we have around 30% reduction in mortality if we do complete revascularization for this patient after stenting the culprit vessel initially. So and we have 45 days. So meaning sometimes we can discharge the patient and make him return in 1 or 2 weeks in order to do the rest of the vessels. So the study included patients that were had complete revascularization within 1 and 45 days after the initial procedure. And sometimes, as we said, in case number 2, we can have multiple culprit vessels. So in that case, we need to do both vessels in the initial procedure, especially if the patient remains in refractory cardiogenic shock after stenting the first vessel. So sometimes we don't need to stick to the guidelines exactly as mentioned. We need to stent both vessels if we think we have 2 vessels causing the myocardial infarction. So after the complete trial, they did a meta-analysis. A meta-analysis is a study that they included multiple studies in it, and they had 7,000 patients in that study, and they concluded that complete revascularization had 31% decrease in relative risk reduction of cardiovascular mortality after complete revascularization. And we'll see why after complete revascularization we'll have this drop in mortality. We'll discuss this later on in this presentation. So as we said, it should be between 1 and 45 days, the complete revascularization, according to this trial.
Yeah, well, actually, putting all of this data together in a meta-analysis is, I would say, will add one publication to your list, but probably will not benefit us to better understand the topic. Because here, the setting and the time when you should do the revascularization is probably of paramount importance. And putting together studies which revascularize between 1 and 45 days means scientifically poor things, in my opinion, because they're two different topics. This is unfortunately one of the main limitations of meta-analysis.
Yes, true. Exactly. So yeah, it was a wide 1 to 45 days is a lot of difference, but because they included multiple study and each study had different timings, so they concluded this at the end. So here you can see we have when we do the complete revascularization, the curve in blue, versus the culprit only revascularization, the curve in red, we have significant reduction in cardiovascular death and new MI. And a follow-up of 5 years, we have a significant reduction, and we will see why in a later slide. I will explain. I will explain why they ended up with this result. But statistically, it was significant.
Yeah,
so if
there is a reduction of 26%. Yes. Of the cumulative incidence of cardiovascular death and MI. But do you have information regarding the TLR or the necessity for any type of revascularization? Okay, no, here it's put. Yeah, it's together with the other one. Yeah, yes. All right.
Yes. Yes, here as well. This slide, you mean, doctor? This slide?
Yeah. Well, this is cumulative. So here you are adding ischemia-driven revascularization to the other outcome. And what I was expecting, since probably you have put more stents, is that there was an increase in the need for recurrent revascularization in the blue line, which is the complete group. Instead, here I'm surprised in seeing that there is not, but the difference and the divergence between the two curves is even higher, adding ischemia-driven revascularization.
Exactly. So it was in benefit of complete revascularization. All the numbers were in benefit of to do complete revascularization after the initial procedure. So they tried to see if they do the FFR. The FFR is when we have an intermediate lesion, for example, and we're not sure exactly if it's a severe lesion or it's more of a benign lesion. So we do FFR to assess this lesion. So they tried to do FFR and compare it to angiographically guided strategy. So they found that doing FFR or not doing FFR was about the same. So they didn't have a mortality benefit when they did FFR to decide if they have to revascularize all the arteries or not in this study. But a new study that was published in the ESC 2022, it was called the FRAME AMI trial. It was the study done in Korea, in South Korea. After initially stenting the culprit lesions, they randomized patients into two groups. A first group where they did FFR to the remaining of the lesions, and a second group where they didn't do FFR and they just do the revascularization angiographically, so visually. They didn't do FFR to this patient. And if the FFR was less than 0.8, then they performed immediate revascularization. And if the FFR was above 0.8, they didn't put a stent in these lesions. And the other group, if the lesion was above 50% or 70%, depending on the artery, they proceeded with revascularization without doing an FFR. And this study showed a benefit of FFR as opposed to the complete trial that showed that there was no benefit with FFR. So here they found that there was also decreased risk of death or spontaneous MI or repeat revascularization for patients that had revascularization based on FFR. Because as you said, doctor, if we put more stents, there is a risk of stent restenosis and revascularization later on. So if we do FFR, we will not put stents for all the lesions. So I think FFR benefited this patient in this topic.
Yeah,
I don't know if you agree.
There is, well, we participated to a study which is still actually running. We finished the enrollment of patients 1.5 years ago, but the primary endpoint will be assessed at 3 years. And yes. It's the iModern study. So we will see in around 1.5 years if an MRI-based assessment of the non-culprit lesions versus FFR is non-inferior. So I think that iModern will put a little bit more information on the table about this topic.
Okay. Okay, so how can we explain this reduction in mortality found in the complete study? So in the complete trial, they tried to do OCT intracoronary imaging to evaluate the plaques, because as you know, we have plaques that are high risk plaque for rupture, and we have stable plaques. So they tried to investigate the remaining lesions, the non-culprit lesion, to see if there is a high risk of plaques or plaques without a high risk. And as you can see here, they did a complete OCT for all the vessels, for the LAD, for the RCA, and for the left circ, in order to better assess the plaques. And as you can see here, we have an OCT image. We know that the plaques that have a thin cap fibroateroma, meaning that a cap thickness of less than 65 micrometer, are high-risk plaques, and they are associated with unstable plaques and risk of plaque rupture. So they tried to find the percentage of these plaques in non-culprit vessels to see if we will benefit the patient by stenting the plaques or not. And as you can see in this graphic, they tried to divide patient in 4 groups. We have patient with we have patient with thin cap fiber, less than 65, and as you can see here, the yellow part of the intimal thickness of here is a high risk plaque, and here we have a plaque that don't have a thin cap fiber. So here it's a more stable plaque, and they tried to also divide patient with obstructive plaques and patient without obstructive plaques. So here it's the diameter is lower, and here it's on the low part it's not obstructive. And they found that 47.3% of patients in this complete trial had obstructive non-culprit lesions containing vulnerable plaques. So here they stented initially the culprit vessel, and they studied the remaining vessels. And they found that around 50% of patients had high-risk lesions in the remaining vessels. And that's why they think by stenting these lesions, we had lower mortality on the long term, because 50% of patients have plaques that are high risk of rupture and high risk of complicating and causing myocardial infarction later on. So they think that the mortality benefit was that we found on the statistic part was associated because these plaques were high-risk plaques in 50% of cases. So here is the conclusion of what we said. So if we need to have a take-home message after this presentation, we need to know that stage multivessel revascularization for patients in stable condition should be performed after the culprit vessel revascularization. It is class 1 level of recommendation A. And same setting PCI should be avoided for all the vessels in the same time, except for a small percentage of patients with are low-risk patients without comorbidities and low-risk vessel, as we said. And we need to avoid complete revascularization initially in patients with cardiogenic shock and plan it for a later procedure for the remaining vessels. And if patient had indication for surgery, we need to do revascularization by surgery. And the FFR, we can do it, but it's not in the guidelines yet because of the complete trial said that we don't have benefit with FFR. But we have a recent study that showed that we had benefit with doing FFR, but it's still not in the guidelines because it's just one study. And OCT can help us in order to classify the lesion if we have a low risk lesion or a high risk lesion for when we want to do complete revascularization. And I want to mention as well that most of these studies studied patients with ST elevation myocardial infarction. We have very few studies about patients with non-ST elevation myocardial infarction for complete revascularization or for just culprit lesion revascularization. But for the studies that we have similar results for ST elevation MI and for non-ST elevation MI. So I think we can use these guidelines for ST elevation and for non-ST elevation MI. And that's it. Thank you.
Okay, thank you, Antoine. I think you did a great job because you covered synthetically, because we didn't have 2 hours of time or more, which would be deserved by this topic. You were able to condense in quite clear messages that you already put in the last slide. So this is good. If I may say something, please, when you refer to a study, always remember to put the bibliography in the same slide. In each slide, you comment on that study, because this will be easier if somebody is going to revise it to go to the first study and to go deeper into the message. But that said, you did a very good job.
Thank you.
Now, let's wait for questions by the audience.
Okay.
I have a question, and it's probably going to be kind of dumb, but I apologize in advance. So you mentioned FFR that can help understand better. We need more studies. I wanted to ask, how common is FFR during routine practice? So is it something, and is it an analysis that is commonly done, or does it need different equipment or something like that? I don't know.
Yes, for sure it needs different equipments. It's a special equipment to do the FFR. Usually we do it when we have an intermediate lesion and we don't know exactly visually if this lesion is significant or not. So we can do FFR. And if you have a number, for example, less than 0.8, if it gives you a number less than 0.8, it means that most probably this lesion is significant. So you need to put a stent inside it. And if the number you get is above 0.8, in that case, you can just proceed with medical therapy and observation. It's mainly used to decide on intermediate lesions if they are significant or not.
Okay, thank you.
Yeah, Claudio, I think that your question was not dumb, but was a well-placed one, because if you were meaning in how many cases in percentage in the setting of acute MI do we do FFR for the other lesions, I would say not very often, actually. In our practice, we do it very rarely, but also looking around in the other cath labs, I would say it's quite rare. So the usefulness in the lack of solid data, the usefulness of doing FFR in the setting of acute MI, where you want to just treat the lesion, the culprit lesion, and also if it's successful, you want to go out, is not very quite so much used. But I have also to admit that there are new tools that will help and are helping, because they are already out. The interventional cardiologist, I'm aware of 2 of them, which are doing the same things that the FFR is doing without placing a wire in a coronary artery. So you can just do the culprit lesion, you take some shots of the other lesions, you stop it, and then you review it with a software which will be able, with a very good accuracy, to tell you the same information of FFR, but doing it after the case. And it's quite interesting. I'm aware of 2 of these tools, which are software tools. One came out very recently, and is able to overcome some of the limitations of the first generation. And I think that these tools will have a good usefulness in this setting.
And there are centers that I think they do it also on the cardiac CT scan. They are trying to do FFR on the cardiac CT scan as well.
Yeah.
May I ask a question?
Yes, please.
Hello, everybody. Thank you for your
Welcome.
Excellent. Thank you very much. Thank you for your excellent presentation. I have a question. When you are talking about the culprit lesion, what is the differentiation? Where is the location of myocardial infarction at distance and culprit lesion? It means when you decide about the culprit lesion based on the angiography results, when you consider the infarction at the distance, is it the place to use FFR to decide about the target vessel or not?
Okay, so for the culprit lesion, usually we need to decide of the culprit lesion based on the ECG as well, because if we find ST elevation, for example, in the inferior wall on the ECG leads 2 and 3 and AVF, we have to suspect the culprit will be the right coronary artery, for example. So if we find a lesion in the right coronary artery, for example, of 90%, and we find a lesion of 70%, let's say, in the left anterior descending, we need here to suspect, we need to start by stenting the right coronary artery, because we think it's the lesion that's caused the culprit lesion that caused the myocardial infarction. I don't know if I understood the question right.
I'm worrying about the infarction at distance, Bernardo. Sorry, but when I faced with two lesions, significant lesions, and one myocardial infarction in the territory of either vessel, how can I exactly?
This is a good topic also, because when you're doing a primary PCI, there is some stress, not only on you but also on the environment. So you need to have a quite clear flow chart. And I cannot tell you the truth, but I tell you what we do in our practice. Obviously, before entering the cath lab, you already have some information from the ECG. And recently, we also tried to implement the echo, which until 5 to 6 years ago was not so much used in the acute setting, in the very acute setting of the primary PCI. But now, since you lose 1 minute or even less just to see the kinesis, so also the echo may give you some more information. Still, there are some cases with some doubts. In these cases, we use imaging. And I would say that ECG plus echo plus angio, obviously, and plus imaging will help you in 97, 98% of the cases.
I got it. Thank you. Thank you.
You're welcome.
May I have a question, sir? Hello, sir. How are you? I am a bit late.
Hello, welcome, Mohammed.
Sir, how are you, sir? Fine,
good.
Sir.
Good, thank
you. Sir, I have a question. Especially in our setup, I am doing my primary PCI calls. What is your approach? Because as far as when we perform the coronary angiography of the patient with STEMI, there is a total occlusion of the vessel. Then immediately after defining the anatomy, we wire the vessel. We just have a balloon or something like a thrombustor catheter. Then we try to get the flow initially. So what is your approach? Are you doing OCT upfront with the wire, or you write your strategy to first of all make the flow inside the vessel and then proceed with the imaging? What is your approach, sir?
Yes, this is a good question. Usually we try to understand better how long also is the lesion, and sometimes if you just wire the lesion, it's not enough to reopen the flow. So doing imaging there will not give you a good amount of information, at least those that you are looking for. So in these cases, usually we do a gentle balloon dilatation in case of very low thrombus burden, or we go with the thrombus aspiration, also according to proximal and I would say midly placed lesions, because in the distal part it could be at least a little bit tricky to deliver the thrombus aspiration catheter. So in these cases we go with a gentle balloon inflation with a 1.0 or a 1.5 balloon, just to see what we see. and then we decide if to do imaging or not. But it's very different. It's difficult to say and to create rules about this. It's also according to your experience and to your preferences.
Thank you, sir.
And from CRO, any question? No questions?
No more questions from me.
I have a question regarding the stage PCI. I wanted to understand if the treatment of the non-culprit lesion are performed with the stent or other treatment are allowed, specifically in the study that you have described before.
Okay.
You can use whatever device that you are experienced with. So that's a normal lesion. So, for example, for Transform 2 study that you know very well, we suggest that one of the possible settings is that since you already know the anatomy of this patient, you may decide to do and to randomize the patient during the completement of the revascularization after a few days. So you can use any type of device according to the lesion type and to your experience.
Okay. So also in the results reported in the graph before, the study allows to choose whatever the treatment is the doctor wants.
Yes,
okay.
It's a normal lesion. It's a normal lesion.
Okay, perfect.
Yeah.
Thank you.
You're welcome.
Sir,
Okay. Another
sorry,
question.
Sir, just last question. Sir,
Yes.
what is your preference of doing FFR during the primary PCI setting of the non-culprit artery? Would you like to go for FFR of the non-culprit vessel during primary PCI setting, or irrespective of that setting after 3 or 4 days or 5 days?
I would like to know also the opinion of Antoine later, but as I was mentioning before, we usually in the primary PCI setting, we prefer to do just a culprit lesion and to stop, not to manipulate too much the catheter, other wires, also imaging catheter or whatever, because the patient is a very delicate patient, and mostly we have to think at the myocardium and not at the vessel itself. So we do the culprit, then we stop, and then we reassess it maybe after 1 or 2 or 3 days when the patient is stabilized.
Yes, thank you, sir.
You're welcome. So I think we are just close to the end. Lisa, if you want, you can interrupt the registration.
Yes, sure.